Hello and welcome to the AHF podcast. I'm your host, Joe Schwab. Our guest today is Dr. Brian Gladnick of the Carrell Memorial Clinic in Dallas, Texas. Dr. Gladnick's study, Mitigating Calcar Fracture Risk with Automated Impaction During Total Hip Arthroplasty, took second place at the most recent AHF meeting. Dr. Gladnick, welcome to the AHF podcast.
Joe, thanks for having me. Honored to be here.
So first of all, tell me a little bit about yourself, a little bit about your background and your practice.
So I'm here at the Carrell Clinic in Dallas, Texas. We're one of the oldest clinics really in the South and really even in the country. We're 100 years old. Our clinic was actually started in 1921 by a guy, W.B. Carrell, who started out as a proponent of pediatric deformity and fracture care. He was actually one of the founders of the Scottish Rite Hospital, orthopedic hospital here in Dallas as well. And so over the last 100 years, what started out as a very small children's orthopedic clinic has grown into a specialty orthopedic hospital. We have all service lines, spine, sports, total joints, foot and ankle, hand, all that stuff, of course. And we have a very, very busy total joints department here. I joined the faculty about almost 6 years ago. We do about, 2,400 joints a year in this hospital we have 5 fellowship trained total joints doctors that do that. And so we got a very busy revision service. We started a fellowship. That whole process began a couple of years ago. We're just actually graduating our first fellow this year. In recent years, we have a 501c3 charitable foundation, so we got approved for REDCap, and we were able to start our institutional registries about 5 years ago based on that. So it's really improved our ability to put out good quality research.
Where did you do your residency and your fellowship?
Yeah, I trained at HSS for residency, graduated from there in 2015, did my fellowship at North Carolina in Charlotte, graduated from there in 2016, spent some time traveling around a little bit, went to Switzerland at the Schultes Clinic and saw Michael Leunig and those guys for a little bit, went down to Austin, saw Tyler Goldberg operate, and something I've been trying to do now every year is take a couple of days off and just sort of travel around the country and watch other people operate. I think it's a really valuable thing to do.
Is Ortho Carolina where you were exposed to anterior approach, or was that with Michael Leunig?
Well, even when when I graduated HSS 2015, it was HSS at that point was still very dogmatically posterior approach, but there was starting to be some people dipping their toes in the water. Michael Lexiades had been doing it for decades, really, at that point. But there were some other people kind of starting to get into it. So there was still some experience. I did see some anterior approach there. But yes, going to Switzerland to see Michael Leunig operate was just an eye-opening experience for me, and watching him do what he does. He's one of the most outstanding surgeons technically I've ever seen operate. And so then kind of coming back, I really wanted to be at a anterior specific fellowship, which is why I went to North Carolina, which was an incredible experience. And probably one of the few years in my training that I ever said, gosh, I would do that again in a heartbeat if I could.
What prompted you to want to study this automated impaction concept in total hip arthroplasty?
The study that we had at the AHF started out as kind of an observation that we had seen over years. And so when I first started using the device, like I said, I had some brief exposure to it when I was in Virginia back in 2016, but then I started using it in earnest when I came to Dallas in 2019. And so when I first started using it, I was just kind of blindly just on power everything. So broaching on power, stem goes down on power, impact the head on power. And the thing is, it's calibrated for the same amount of newtons of force that you want to engage the trunnion. I remember when they first came out with this thing, it was a lot of the messaging from the companies was, this is a panacea for fractures. You'll never break anybody with this thing. It's calibrated, it's safe, you're in line. And my experience was that was clearly not the case. That every once in a while we were having a fracture. Just as you would if you're broaching by hand. Every once in a while you're going to have a fracture if you're doing enough hips. And so we went back and looked, and in fact, when we looked at that study, if you look at our overall rate, I think it was something like almost 1,600 hips. We had 17 fractures at a rate of 1.1%. So it was clear to me that it's not a panacea, but it didn't seem much different than mechanical or handheld broaching. And it's just that there's certain patients that are going to have fractures. But one thing that did become clear to me, as we use this thing more and more, was that there were certain situations in which I was just naturally saying, that's a case I'm not going to put the final stem down by hand. And I know, and so we noticed very early on, it seemed like all of our fractures were occurring not with the broach itself, but with the final stem. So I would be, and I was ruthlessly aggressive with this thing, just full auto, just wedging these stems in super tight. And then say, okay, it looks great. I'd take the broach out, and then then you put the stem down. But every once in a while, you'd have a fracture. Be like, gee whiz, we were, like I said, ruthlessly aggressive with these broaches, but then all of a sudden we put the stem down, we have a crack. Why did that happen? And one thing we started to notice was that in situations in which you imagine when you have that final broach in there, and we just look at it, and if there was a rim, like a sort of a cushion of cancellous bone surrounding the outside of the broach, that was a situation I was pretty comfortable saying, okay, it's almost like a cushion, right? It's gonna be a safe situation to impact that stem by power.
So what did your study actually find? What were the results?
It brought our fracture rate down from like 1.2% to 0.6% by going that selective. Now I will say it was certainly clinically significant to me to see basically a 50% reduction in fractures.
Were you using a consistent stem throughout the entire time? Were you using a mixture of stems? Tell me a little bit about that.
Yeah, I'm pretty consistent with my stem. I use a triple tapered collared HA coated stem in virtually almost everybody. I excluded patients that we cemented, or certainly any kind of conversions, revisions, things like those were all excluded. So the only people that were allowed to be included in the study were primary triple tapered stems.
Based on what you found, what advice would you give to surgeons who are using automated impaction?
First thing I would tell them is to go for it. I think it's a real benefit to the surgeon themselves, and we have an ongoing, a couple manuscripts in publication right now, but a ongoing multi-centered RCT, prospective RCT, looking at a variety of different things, not just accuracy of component placement, but also things like operative time, broaching time, fracture rate, and also biometric data, looking at the burden of effort on the surgeon themselves. So they had all the surgeons in the study wearing a biometric vest with real-time EMG data. So looking at your muscle activation, your deltoids, your biceps, your pecs, things like that. It's a lot less wear and tear on your body. And so I think we'll be operating longer and more comfortably with these devices as we go forward. Number two, I think we're doing a better job putting these stems in. I think if anyone who uses these devices, and it's hard to quantify in the study, but there's something very palpable about when you broach with automation, that the consistency of your broach envelope is just much more pleasing to the eye and pleasing to the feel of your hands than when you're doing it by hand. I think ergonomically, it's easier to control the broach. Think about a really tight muscular patient, or how these, think about a patient who, as you grow larger and larger in your broach size, how sometimes the anatomy will force you into that increased anaversion. You're trying so hard to resist that, but you're fighting a belly or fighting their musculature, and it's kind of forcing your hand out. It's much easier in my mind to resist that using automation. It's not a panacea for fractures. You can definitely still crack somebody with these things. But if you pay very close attention to the relationship between the broach and the calcar, if there is a full circumferential cushion of cancellous bone between your final broach and the calcar, go ahead and put it down by power. But if there's any part of your broach that's directly contacting that calcar, just be safe, tap out the stem and put it down gently by hand.
Any advice that you would give surgeons who aren't using automated impaction? Would this be an indication to consider using it, or what's your advice there?
I think if you've been broaching by hand for 20 years, you're very used to the pitch changes and the feel of a stem as it engages the proximal bone or distal bone. What that feels like. It feels different when you use automated impaction, and there's some just things where you have to just use it to get used to those things. But the learning curve for it is very easy. We train our fellows on it. They have it within like a week or two. They got it. It's not terribly difficult.
So is it going to give you an extra 10 years on your practice, do you think?
I hope so. My plan is to work until I drop dead. So that's the.
Hopefully not anytime soon.
That's right.
We really appreciate you submitting your poster to the AHF this year. We congratulate you on your victory. It was an excellent poster. It had great scores from the scientific committee, and we look forward to you submitting further research in the future.
Well, thank you, Joe. Yeah, we were honored to have that recognition, and hopefully much more coming forward.
Thank you for meeting with me today, Brian.
Thank you. Thank you for your time.
Thank you for joining me for another episode of the AHF podcast. If you want more information, you can check us out on Facebook, LinkedIn, or X, or you can visit us at our website, anteriorhipfoundation.com.